In this second episode in our series on recommendations to the Trump administration on advancing healthcare quality, we're doing something different. We're turning the spotlight on our colleagues at Leavitt Partners and asking them to talk about digital quality and data exchange. We agree with Leavitt Partners' recommendations, and you can find NCQA's own recommendations for digital quality in the show notes. I'm Andy Reynolds with NCQA. Today, I'm handing the mic to Ryan Howells of Leavitt Partners because Ryan is what I call a full spectrum thinker. He can get into the weeds and talk technical details, but he can also soar to a higher level and give context that makes sense to people who don't have a background in computer science. It's time for a clarifying conversation with Ryan Howells. We appreciate you being here.
Glad to be here, Andy.
What is Leavitt Partners and what do you do there?
I'm a principal at Leavitt Partners. Leavitt Partners was founded by former Secretary Mike Leavitt when he left public office about 14 years ago. It's focused on both public and private collaboration and ways to advance federal policy and national standards. Our purpose is to develop standards and policy making to achieve the triple aim.
The triple aim, of course, being better patient experience, better population health, and lower costs. You are the principal author of a publication I have found fascinating. One thing that jumped out at me is the title of the document, New, capital N-E-W, New Ideas for the Trump Department of HHS. Is this different than what you had advised the first Trump administration or what your firm would have told the Biden or even a Harris administration?
It certainly, Andy, builds on work that has been done previously. But the reason it's new is the Trump administration has indicated they want a generational change in the way federal infrastructure is managed and structured. We're talking about new ideas, break the glass ideas in terms of how could this scale faster? For example, API or application programming interfaces have been around for 12, 13 years, but have not been able to scale at the level we would like. And to give some background, Andy, when you get on the internet on your phone or your desktop, the way tools and applications work is through the application programming interfaces. The problem with healthcare is we have not been able to implement those at scale. If we can do that, we can take advantage of the innovation economy and eliminate waste and burden and administrative cost associated with healthcare transactions.
You say we haven't been able to implement at scale. What's been in the way?
Historically, we have used healthcare-specific standards that are more antiquated technologies for how to exchange data. Some of the other standards, by the way, Andy, have been proprietary, so that's one of the other problems. We have not used internet-based standards. Internet-based standards are these application programming interfaces. All of those apps on your phone use these APIs to access data from different systems. We just have not used those at scale in healthcare for different reasons. One is we may not have been ready with the infrastructure. Two is we thought healthcare was a unique snowflake and we needed to do things differently. And three is the federal government hadn't been promoting the use of APIs the way other industries were. And there's really two things that scale in healthcare. One is open standards and two is federal policy. So when you have a combination of open standards and federal policy, you can see this scale across the country.
One thing that I found intriguing about your recommendations is it's clear from the opening page that this is about technical topics, but on the top of page 2 in the executive summary, the focus shifts from technology to psychology. You write, trust cannot be mandated or regulated. Trust is extremely hard to develop, maintain, and grow. This is interesting how a technically focused document has suddenly come to focus on people and what they feel. What are your thoughts on the integration or importance of trust amid these technical topics?
Even though we've been talking about technologies, it's actually people, process, and organizational barriers that we have. There are data use agreements, contracts, fees, business models, all types of things that prohibit us from sending information in a way that is digestible and in real time. Those things are barriers to being able to scale interoperable healthcare. Trust has to be earned. And unfortunately, trust between payers and providers are at an all-time low. Whenever they get together, they typically are talking about sensitive topics like prices and contracts. We are asking them to get together in a new and different way where both organizations succeed by reducing overhead, by reducing administrative waste, by reducing burden, by implementing these APIs. The hope is we can build what we're calling tables of trust for payers and providers to exchange information in a new and different way and help their organizations reduce manual overhead that both are experiencing as a result of antiquated workflows.
Tell me more about the tables of trust.
They're literal, Andy. So I'll give you the example. Leavitt Partners had an opportunity in Utah to come together with multiple payers, multiple providers, and the state to talk about how we could implement APIs at a state level. It took a while to get to a point where A, folks understood what we were trying to accomplish, and B, we could establish trust. We could earn their trust by providing transparency and specific goals that we wanted to achieve together. When we all recognized we were marching towards the same goal, this CMS interoperability rule called the Prior Authorization Interoperability Rule, which needs to be implemented by 2027, it became easier for us to talk. And that's when it started to open up. Wow, we could take infrastructure we've developed for one use case and use it for multiple use cases. We realized Fire API infrastructure built a few years ago called the Patient Access API could be reused for other use cases required by the CMS rule for digital quality measures and digital quality measurement. And that's our hope, that we can help organizations understand infrastructure can be used for different use cases. You don't have to buy one-off solutions to solve different problems.
I know you're interested in improvement at scale. So how do you think what you did in Utah can scale to the rest of the country?
Tables of trust test what needs to occur for this to work in production. So there's an opportunity now to convene stakeholders with different states to say, how do we actually expand the Fire API ecosystem and all of these APIs that are required for clinical data exchange, for claims data exchange, for digital quality measurement, for public health use cases, all of these use cases that could use the same API infrastructure. How do we scale that? We did that work in the Caring Alliance. That was a group getting individuals more access to their healthcare data. Same thing with the Da Vinci Project. These were laboratories of trust, laboratories of learning. We'll do that with public sector partners in a way, and that starts to lower the burden on everyone. Everyone can then take advantage of the returns on investment these pilots are showing.
I was struck by something you wrote in your recommendations, and that is, it's very hard at the national level to grow trust. It must start at a regional or state level. You're really espousing a bottom-up approach, aren't you?
At least initially we are. It's hard to establish trust nationally with literally hundreds of payers, thousands of providers, millions of patients. As it relates to provider to payer data exchange, it's something we have not done nationally yet. So we're looking to start smaller, where for most states, you could get maybe 3 or 4 payers and 3 to 4 providers and have more than 50, 60, 70% market share in a lot of states. That can start to scale trust. The other thing is state policies may conflict with national policies as it relates to data exchange. So you need to accommodate for those state policies in any data exchange. If you start with national and don't accommodate for the states, you start tripping over each other. There'll be an opportunity to build trust in a meaningful way locally first. They already know each other. We need these localized approaches where we can put things into production and say, all right, now what have we learned from those?
For a different perspective on what I was learning from Ryan, I went to NCQA's top doctor.
Hi, my name is Eric Schneider. I'm the Executive Vice President for the Quality Measurement and Research Group at NCQA.
Eric, what's your take on what we've heard from Ryan so far?
Ryan expresses the direction the country needs to go in terms of interoperable exchange of healthcare data to support quality measurement, quality reporting. Imagine you wanted to transfer money somewhere and you had to go and get the bank identities of 3 different intermediaries to make that exchange possible. That would be totally inconvenient, but that's today's healthcare world. The retrieval of information is often manual. It's faxes, it's phone calls, it's notes exchanged. Bringing all that together is labor intensive. What Ryan and others are advocating is the policy environment, the payment environment, and the data infrastructure that makes information exchange seamless in healthcare and provides a better experience for both patients and practitioners who are delivering care. That's the world we're used to for retail or travel or banking. That's the world all of us experience the convenience of.
I was struck by how Ryan elevates technical discussions of interoperability into discussions of trust. What did you make of that?
It's actually a really important insight that Ryan served up. Standards exist to the extent that people agree to abide by the standards. We have US dollars. It's a piece of paper with print on it. It has no power unless somebody believes it has value. When we exchange a dollar bill, both of us know what that means. That's the trust element. If I give you a dollar bill and you interpret that as a piece of paper that can be used to heat your home, the system breaks down. Same issue comes up with any technology, banking, transportation, education, electricity, highways, everything you can think of has standardization. An international committee sets electrical standards. So when we plug in an appliance, we know what the voltage will be and all of the other things that go with electricity. That's the role that HL7, Health Level 7, plays. That's the industry body. And then you have government helping to convene the different stakeholders. Most of the standards work up to now recently have been done under the Office of the National Coordinator for Health Information Technology.
As you travel around the country and you talk about these issues, what do you find most people don't know or misunderstand about where we are or where we need to go?
There's a lot behind the curtain in terms of technology. People will hear the term API or application programming interface. Sounds kind of mystical. When I first heard it, I had no idea what people were talking about, but that's the shorthand for technology that pulls and retrieves information in a digestible, interpretable format. We're all familiar with the smartphone interface or the web browser. We don't appreciate that there's a tremendous standardization and technology running in the background. When you open a web page, you're not opening an actual page. You're giving an instruction, and software is retrieving data from a variety of sources. If you check a weather forecast, for example, there's a bunch of data being collected, processed, and served to you. We don't need people to worry about that. We just need it to happen in the background. But what we don't have in healthcare has been the engineering and policy and contract agreements to set up all of that and the standards so that retrieval can happen automatically on the fly in a secure fashion to serve up the experience that people expect.
Ryan, let's get back to Leavitt Partners' recommendations to the Trump Department of Health and Human Services. I'm intrigued by the heading and subheading on page 1. Kill the Clipboard, a federal policy and industry roadmap to accelerate innovation and cut administrative waste. To me, the clipboard stands for any manual process. Is that what you mean when you say kill the clipboard?
I've been doing this for a long time, almost 30 years, and we have made substantial progress in data exchange, interoperability, modernizing data standards. But when I go into my doctor's office and I still have to fill out a clipboard with a piece of paper on it, with information I know they already have, it is painful. So the best representation of whether we are making progress is I don't want to ever go into a doctor's office and fill out a clipboard. If I could just not fill out my health history, my demographic information, whether information should be sent to my doctor, if all that is just in the doctor's system, I would say we have made progress because at that point, it will be real to the individual. Think about it in terms of digitizing all of the healthcare data and making sure that it is with the right person at the right time in the right place to make the right decisions. When that happens, we'll know we've made significant progress.
Let's look again at that subhead at the top of the first page of your recommendations. A federal policy and industry roadmap to accelerate innovation and cut administrative waste. Tell me more about what innovation and what waste you're talking about.
So we'll take the waste first. Waste is related to the manual processes to exchange data between systems. We're trying to eliminate that. I don't think anyone wants to be in the business of manually faxing papers back and forth or trying to grab charts somewhere. How do we electronically send that to the payer? That's the real trick. On the innovation front, there's billions of dollars going into venture capital backed startups that are solving these problems. It's difficult for organizations to get access to health information, and we're trying to make it easier.
Let's turn to some of your more specific recommendations. First on your list is eliminate antiquated interoperability policy and better align across the federal government. What do you think is possible in that regard, and what benefits would that bring?
Let's talk about policies related to clinical data exchange. Most of those have been developed by the Office of National Coordinator for Health IT, or ONC, because they have regulatory authority over the electronic health record vendors, which most providers and hospital systems have implemented. 15 plus years ago, we had very little electronic health record technology out there. Electronic health record vendors would build technology based on things that the government had asked them to do, as well as other innovations they had. That's what we call certifying the functionality. Now we are nearly fully penetrated on providers and health systems in terms of electronic health record technology. 90+% have these systems installed. As a result, we now need to pivot that policy to certifying data sent outside of those systems. So instead of certifying the functionality, can we pivot to actually certifying the APIs? And if we can start to certify the APIs, EHR vendors will have flexibility in what they build and how they build it. If we can do that, Andy, there's a ton of value because that will allow systems to talk to each other, be interoperable. That's what we mean by pivot the policy. There'll be all types of innovation that's going to occur, and it'll unleash that. More innovation, reduce burden, reduce administrative costs, better interoperability, more consistent data exchange, better data, and better insights at the point of care.
I get that certifying functionality is distinct from certifying the API, but for non-technical people, that may sound like a distinction without a difference. So can you help tease apart or understand the significance of certifying functionality on one hand versus API on the other?
If you're running a company, you don't want people to tell you how you need to do things in your company. The problem we have now is the certification of the functionality inside the EHRs is the government telling these companies how to build their product. If instead they said, you can build your product any way you'd like, you can compete on price, product, and service, similar to other industries, it needs to live in a standardized, open standard-based way using these APIs. If we can do that, it allows vendors to innovate and allows other products to solve other use cases. Right now, there is widespread adoption of what they call the patient access API, which means that patients can access both clinical and claims data. The problem is those FHIR APIs are not in production today between payers and providers.
Excuse me, Ryan, what do you mean FHIR APIs between payers and providers are not in production?
In production just means it's being used in real life. It's not in a test environment. It's not somebody's idea. It means it's being used.
Got it. Thanks. Please continue.
FHIR APIs are not in production between payers and providers. What we're trying to do, Andy, and what the CMS rule does is implement FHIR APIs at scale between payers and providers. Now, why does that matter? Because we have all these different use cases we can solve. If we can send all of this information using these APIs to another source, we can start to run digital quality measures and see insights in real time for care coordination, for improving quality and improving outcomes. So B2B, business to business, FHIR exchange is something we're excited about. And it goes back to my comment earlier about tables of trust. If we can get multiple payers and providers in the room talking about these topics, we can discuss the multiple use cases we can accomplish by leveraging the same FHIR-based architecture. Before you can do that, you need to have data use agreements. You need to have technical connections established. There's all kinds of things you need to have to make that work at scale. It becomes a matter of sitting everybody down and saying, okay, let's figure this out. Let's make sure we know how to connect to each other digitally.
What do you need to get there? How can we go from point A to point B?
We need more payers and providers to raise their hand and say, I'm willing to be an early adopter of these technologies to make it easier for my employees to exchange information between different entities and to lower the burden, overall cost, and increase the innovation in the ecosystem. More people to raise their hands and figure out ways that we can sit down to solve these issues would be wonderful.
Why do you think people haven't raised their hands?
Because they have day jobs. There's a ton happening. Providers are getting pinched in terms of reimbursement, and even payers are getting pinched on the other side in terms of costs associated with doing business. There's obviously some uncertainty on the federal side as well. The combination of all those factors that make it difficult for people to carve out extra time for innovation. They kind of have to already do it, Andy, for the CMS rule in a year and a half. And we're just trying to say, let's go early. Let's figure out how to make this work early and get the benefit of what these APIs can provide.
I think that's a specific and optimistic place to end. Ryan Howells is a principal at Leavitt Partners and the lead author of Leavitt Partners' New Ideas for the Trump Department of HHS. We will link in the show notes to the Leavitt Partners recommendations and NCQA's own recommendations to the Trump administration. Ryan, thank you for joining us on Quality Matters.
Thanks, Andy.
Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.